The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Welcome, TMD warriors. I am Tony Urbanek, and we are gathered for the next episode of TMD Demystified. Today, we're going to be talking about a very timely and important topic that applies to both practitioners, dentists, oral surgeons in particular, and even to patients. I understand that there's an increasing number of patients who view these episodes. But the topic today, having to do with TMD, revolves around the fact that TMD generates some strange pains around the face, neck, oral cavity, upper back and shoulder, etc., that we've talked about many times. But one of the very interesting things that patients frequently report, and very specifically report, is they confuse the TMD pain generated with toothache, or in my specific field as an oral and maxillofacial surgeon, impacted wisdom teeth. Now, let's tackle the wisdom teeth thing first, because in my now 50-year career as an oral and maxillofacial surgeon, I have seen many, I don't know how many, less than 500, but more than 100 episodes, many more than 100, probably something less than 500 cases of patients who presented to me on referral or their direct referral from the patient themselves, saying that their wisdom teeth hurt. And that, fortunately for me as an oral and maxillofacial surgeon, they needed their wisdom teeth out. So I would get an x-ray and do an examination and take a look at the usually 4 impacted wisdom teeth, whether the patient be 16 years old or 60 years old, and make a diagnosis and whether or not I suspected the pain was coming from the wisdom teeth. Most of the time it was. You'd have an inflammation, you'd have damage to the adjacent tooth, you could have a cyst or a tumor around the impacted wisdom tooth, but very frequently, especially in younger individuals, 15, 16, 17, 18, you take a look at the x-ray, you do an examination inside the mouth, you would palpate around the wisdom tooth, the impacted wisdom tooth itself did not generate any pain. You couldn't get pain on, quote, palpation of the area. No matter how much you pushed on the area over the impacted wisdom tooth, you couldn't generate pain. And you looked at the x-ray and you saw no x-ray evidence that that tooth should be symptomatic at all. In those cases, I would sit down with the patient or the patient's parents and the patient and explain to them the reasons why impacted wisdom teeth need to be removed, which are many. I think I still recall I don't do wisdom teeth removal anymore, but I still recall the pattern. Wisdom teeth can cause the major malfunctions are cysts and tumors, and malocclusion of various kinds. And the most important one is damage to the adjacent tooth. That actually, impacted wisdom teeth frequently cause damage, especially decay, to the adjacent wisdom tooth, needing eventually the removal of the second molars because the third molars hadn't been removed. But this is not a lecture on why you take out wisdom teeth. But I would go over that with the patient and say, you certainly need your wisdom teeth out for these reasons, but your wisdom teeth are not causing your pain. Your wisdom teeth are not causing your pain. I'm also aware of many of my colleagues, both general dentists and oral and maxillofacial surgeons, who would not go through that process with the patient, and they say, sure, well, whatever reason you think your wisdom teeth need to come out, we'll take it out. But in those cases, the patient would come back, even though their wisdom teeth were removed, and still having pain and wondering why now their wisdom teeth are out and they're still having pain. Well, most likely, I can't go back to all those cases that I observed or saw over a 50-year period of time, but it is highly likely that in each and every one of those cases, the pain that the patient thought was associated with their impacted third molar, wisdom tooth, was actually pain generated from the temporomandibular joint. And the same thing applies to the frequent patients we see who come in and claim that they have their pain is coming from a bad tooth, a toothache. And patient and general dentists are confronted all the time, very frequently, with patients who present to their office in pain, and they say, I have a toothache. And so the general dentist will then go through his usual standard consultation, x-ray examination, and announce to the patient that I don't see anything wrong with this tooth or any teeth in this particular area of your mouth, always in the posterior, always in the posterior. So there are two separate scenarios. As the patient comes in and says, I have a toothache, and the patient who comes in and says, I have pain, my wisdom tooth is hurting. Both of them, on examination, are seen to be not creating pain. There's no reason for the pain. You don't see any decay. There is no pain on palpation. There is no cyst. There is no tumor. There is no clinical reason to treat either the tooth in general or the impacted tooth. And then it is up to the doctor to inform the patient of that fact. It's confusing. It's confusing to the patient, it's confusing to the doctor. And as I've already intimated, some of my oral surgery colleagues just go ahead and take out the wisdom tooth without actually telling them that, no, I don't think your wisdom tooth is causing this pain. I don't know what's causing it. They may not, and in most cases, they don't relate it to the temporomandibular joint. But today we're going to talk about technically how inflammation within the temporomandibular joint can create in the patient's mind, in the patient's physiology, pain. Either they think it's coming from the tooth or they think it's coming from an impacted wisdom tooth. And it's easy to explain when you understand the pathophysiology of exactly how inflammation in the joint reacts, inflammation in the temporomandibular joint reacts. But so the topic of today and the title of today is, why does my TMD sometimes feel like a toothache? That's the title of today's episode. Why does TMD, temporomandibular joint disorder, sometimes feel like a toothache? Well, the explanation is the same explanation of why TMD sometimes comes across as upper back pain or upper back and shoulder pain and tightness. Also, the same explanation of why TMD, not infrequently, comes across to the patient as arm, hand, finger tingling and numbness. We've talked about that many times, but the pathophysiology is all the same. How does inflammation in that joint, from a damaged joint, you have to have a damaged joint to start with, damage due to whatever reason, there's only three causes, there's only three reasons that people damage their temporomandibular joint: chronic clenching and grinding, bruxism, acute trauma of various kinds, especially motor vehicle accidents and whiplash injuries, and then functional malocclusions where your teeth do not fit together evenly, significantly overloading the joint, damaging the joint. But all three of them share the concept of damage to the temporomandibular joint. Damage to the temporomandibular joint creates inflammation within the joint. If the inflammation doesn't go away, then there are a cascade of events that create these disparate feelings, these disparate symptoms around the head and the face, the neck and the shoulders, and even into the arms. So what is that pathophysiology? We've talked about it many times, but today I want to limit it to this concept of it feels like a toothache, and this is not unheard of. It comes across in many dental offices this way, and the dentist scratches his head and says, "This tooth looks fine." Well, here's what's happening. Again, we've discussed it before, the pathophysiology, which is what has not been worked out before. This is why the dental schools don't teach about it. They think it's complicated. They haven't figured out what the orthopedic surgeons know about inflammation in the joint. Orthopedic surgeons know all about what they call joint splinting. When a joint becomes inflamed, a signal, a autonomic nervous system, a nervous system signal through the autonomic system, sympathetic portion, sends a signal to the brain, specifically in and around the brain stem, says, "I'm inflamed." So there's a signal, a message that's sent from the joint through the nervous system to the brain that announces, "I'm inflamed. I need help." And the body is excellent, is an excellent mechanism. It's a self-correcting mechanism if you allow it to self-correct. And the injury isn't too bad. Well, in this case, you got a bad joint, it's inflamed, it sends a signal to the brainstem announcing, "I'm inflamed." The brainstem says, "I see you're inflamed, I'm going to help you out. I'm going to help that joint heal." Well, what's the best way to allow a joint to heal? Well, limit the movement in the joint to allow healing. If you have a bad joint, the orthopedic surgeons learned thousands of years ago, you rest the joint. If you have a bad knee, you put the patient on crutches. If you have a bad elbow, you put the patient in a sling. Now, orthopedic surgeons, have the opportunity to have external devices that rest the joint. Well, dentists and oral and maxillofacial surgeons do not have an external device that they can allow to rest the joint, but we now have an internal device that rests against the upper front teeth, disoccluding or taking the load off the back teeth, where 90% of the loads on the joint come from. So you disocclude or separate the posterior teeth, taking 90% of the loads off the jaw joint. But the point is, the pathophysiology is the same between the orthopedic joints, hip, knee, elbow, and the temporomandibular joint. When this joint becomes inflamed, it sends a signal to the brainstem. It says, "I'm inflamed." The brainstem says, "I'm going to help you out. Don't move the jaw," and sends out an autonomic nervous system message signal to the muscles that move the jaw, and not always to the same muscles, not always on the same side, but you will get variations of where those signals are sent. And there are many muscles, without going into the specific names. We can. And patients will complain of where those muscles are attached to the bone, whether they be attachments to the mylohyoid or the masseter or the temporalis, and patients will come in. They'll literally show you it hurts there every morning. But the point is that signal goes to the muscles that says, "Tighten up, contract, tighten up, don't move the joint." And that is the mechanism that the dentists have never learned, the orthopedic surgeons know all about, and the reason why a device that separates the back teeth, like this device, separates the back teeth, will decrease the inflammation enough where the signals don't get sent and the inflammation goes away, because the muscles do not get the signal to tighten up. that pull on the bone, and where the muscles are attached to the bone is where it stimulates the nociceptors on in the periosteum of the bone, and patients will complain of pain here, and specifically, if the signal comes to tighten up the masseter muscle, which inserts right here, the patient can confuse that pain, which is actually pain in the bone, which is right around the tooth itself. So whether it be a second molar or a first molar or a third molar, wisdom tooth, patients will experience pain right there, right literally on the bone that supports that tooth. And patients will present to the dental office, to the oral surgeon's office, and say, my wisdom tooth hurts, or I have a toothache. I must have decay in that tooth. The workup is accomplished, the workup is done, the x-rays are taken. Nobody sees any reason to have pain.